Good morning. This morning we're going to be talking about musculoskeletal disorders, chapter 20 in the pediatric nursing book. Musculoskeletal is really hard, so lots of deaths today. We're going to be talking about the anatomy and physiology of the musculoskeletal system, common disorders, assessment skills, diagnostic tests and lab values, nursing interventions, hospital interventions, home interventions, so lots and lots of different things. So back to the basics, anatomy and physiology. So the musculoskeletal system is composed of your bones, your muscles, joints, tendons, and ligaments that interconnect. Muscle contraction is innervated by the somatic nervous system. Remember that fetal development of the musculoskeletal system begins with the formation of pure cartilage, which is then transformed by osteoclast and osteoblast formation. The rapid formation of skeletal structures makes abnormalities somewhat common. And so when we think about those abnormalities, remember your environment, genetics, trauma. Your bones are cartilaginous structures that develop when kids are growing and developing. Growth plates are open in kids. That's especially important to remember, especially as we talk about fractures. It can make certain diagnoses more difficult due to age-specific qualities of bone and joint structures. Once maturation occurs, bones are characteristic dense osseous structures. As a general rule of thumb, kids' skin, muscles, and ligaments protect the maturing bones. That way that those parts are if those parts are weakened or not developed, the bones do suffer, which is important to remember. Anatomy of the growing bone, we have the epiphysis, which are the ends of the long bones. Excuse me. We have the physis, which is the segment of bone responsible for lengthening during growth. We have the metaphysis, which is the wide part of the long bones where the diaphysis and the epiphysis meet. The diaphysis forms from the primary center of ossification, sometimes also known as the shaft. The periosteum is a sheath covering the bones. One of the big things to remember on the physis is injury to the physis can cause long-term impact of a child's physical development. You got to remember that child's bones are different from adult bones. Adult fractures must be aligned perfectly, whereas children with open growth plates will remodel or form new bone to repair the fractured area. The younger the child, the better remodeling will occur depending on the extent of the deformity. But injuries that do occur after the kid is about 16 years of age will not have enough time to remodel completely. So risk for physeal arrest with subsequent growth disturbances present. This is also one of the reasons why your infants, their bones are more bendable. That sounds terrible, but if you have an infant with a fracture, it typically is something major, whether it's abuse or trauma, because they just have, their bones were more flexible because they're not as dense. Skeleton, kids have the immature skeleton, which is increased resiliency to stress. Thicker periosteum, increased potential to remodel, which is amazing that they're able to do that. Shorter healing times, presence of the physis, injury pattern in growing bones. And again, bones tend to bow rather than break. You can see a compressive force, which is a torus fracture or buckle fracture. And we'll talk about that more when we get it in the fracture segment. Ligaments and tendons are stronger than the young bone. Bone is more likely to be injured than soft tissue. The periosteum, which is that sheath covering the bone, is active in kids. This means that the periosteum is developing new bone and is also supplying blood. Kids tend to heal their fractures faster than adults. And so the big advantage to this is the immobilization times are shorter, but the disadvantage means that misaligned fragments become solid sooner. You need to anticipate bone remodeling, which is the absorption of bone tissue when new bone is simultaneously deposited, if the child has more than 2 years of growth left. Mild angulation deformities, less than about 2 millimeters, often correct themselves. Rotational deformities, such as those that are twisted, require reduction or placement of correct alignment because these will not remodel. Fractures in kids may stimulate longitudinal bone growth, and some degree of bone overlap is acceptable and may even be helpful. Children do not tend to get as stiff as adults after immobilization, yet they still need to regain strength after immobilization in 1 to 3 weeks of slow return to full activities once the pain, the swelling, the stiffness have resolved. So don't immediately educate them to just go right back into full activity. They do need to build up to it. After casting, a callus is formed but still may be fibrous. A provisional callus is temporary and still developing new bone. A definitive callus forms permanent osseous or bone tissue after several weeks. Kids should avoid contact activity for 2 to 4 weeks once they're out of cast. So start them slow and get them back involved, but those contact activities like football, something that's going to be actual contact, they need to avoid. So the evaluation tools that we're going to use all require understanding of the anatomy. The overall assessment involves simple to complex physical tests to evaluate themselves. We want to do inspection, palpation, range of motion, lab tests if indicated, x-rays, CT, MRIs, arthrograms, and the lab. There is a great chart in your book that kind of talks about the CBC, because remember you want to check for anemia, clotting disorders, a CRP, the SED rate, which all kind of looks at inflammation, rheumatoid factor. Remember their calcium and their phosphate levels can indicate how their skeletal system is, and then aspiration. If you have somebody that you're aspirating a joint, you always send that in for pathology. Understanding normal motor development and screening tools also help determine problems or potential delays. Remember, the motor development is a child's increasing ability to move and interact with the environment. And we, make sure, remember, as we talked about that growth and development, that the rate does vary among individuals as long as it follows a predictable pattern. You do have to remember that some, kids, due to congenital malformations, that they may be behind. So you really do want to take a thorough history, a birth history, the degree of prenatal and postnatal care to incorporate all of that into your plan of care. When you're doing your general assessment, you're going to do that physical examination. And what's great about the skeletal system, especially when you're talking about the extremities, you always have one to compare. So if they have a hurt wrist, compare it to the other wrist. Is it more swollen? Is there decreased range of motion? But that's what's really nice, is you can compare it. But you're going to do your physical examination, history taking, height and weight, any diagnostic imaging if it's ordered, any lab testing if it's ordered, motor develop evaluation, and then of course family expectations. When we talk about emergent care or initial nursing care, remember PRICE, P-R-I-C-E, and that's kind of new. When I was in school, we always remembered RICE, R-I-C-E, but it's actually, they've added a P to it, to PRICE. So you have protect, rest, ice, compress, and elevate. and that's with any new injury. You're going to perform neurovascular checks, and if it's something that requires surgery or casting, you're going to continue to do those. Natural alignment is best to prevent deformity, and it improves function. If they're splinted, cast, or braced, you're going to make sure that that stays intact, and reinforcement of any bandages or splints is needed. You're going to monitor their weight-bearing status. You're going to teach and monitor the use of assisted aids as needed. And remember, you're going to also teach this to the family. Activity levels, as indicated, you're going to give all pain medication as ordered, and you're going to really watch for the side effects and how much they're using it. And remember, as we talked about the pain medications, you need to do an appropriate pain assessment. And that may be different on the child based on the developmental age, based on the cognitive age. And you're going to educate both the patient and the family on non-pharmacological methods, especially distraction is particularly helpful in this situation. But you can use any of them. Problems or concerns that require immediate medical attention are slip bandages or splints, high fever, foul odor from the bandage or splint. You're going to want to make sure and provide support for post-op coping and family support or community resources for the family. You're going to get the interdisciplinary team involved, and this should include social work and rehab services. You're going to want to make sure the patient and their family understands school and gym class as well as sports participation restrictions. And you may need to be educating them on toileting and other activities of daily living depending on where the cast or splint is or surgery, and of course educate them on the follow-up visits. Fractures in kiddos are more complicated than adults due to the nature of maturing bones, the cartilage features, and open growth plates. So we have the torus fracture, and that's your buckle fracture, and those are some of the most common among kids. I see those a lot, actually. The mechanism of injury is usually a direct fall onto an outstretched hand. So remember, they're falling down. Let me get in front of the camera, and they're hitting that hand. But it basically compresses that bone. And so sometimes buckle or torus fractures, you can remember the acronym FOSH, F-O-O-S-H, fall onto outstretched hand. F-O-O-S-H is your buckle fracture. Fall onto outstretched hand. Occult fractures are common due to the maturation process. An occult fracture of the tibia is called a toddler's fracture. An occult fracture is rarely seen on emergent x-rays, but the child may cry or refuse to weight bear on the affected extremity. Remember, if you have an x-ray of an acute injury and it doesn't show anything, but the kid or adult even is not getting better, you do need to re-x-ray that in a week or two just to make sure that there wasn't a fracture that shows up then. So we typically use walking boots or casts in the lower extremities, and upper extremities or braces or slings, but sometimes that's the most common, but we sometimes do other things. You do want to repeat the x-rays in 3 to 4 weeks to know if they are getting a callus formation along the seam. So basically when they have the fracture, like this is the fracture, you'll start seeing this little callus formation over the top of it. It's super cool. I encourage you to look it up online under images, because you can always tell if there's a fracture that's healing. Excuse me. So, educating patients on after an injury is no running, jumping, climbing with splints or casts, No activities with balls or bicycles. Do not insert food, toys, or other objects into them. Think about your kiddo that has the arm cast and it's itching, so they want to stick stuff down in there to scratch. Don't do that because they can really cause damage to the area. They can scrape it and it can get infected. No slings around the neck to the bud, and slings, because remember, you don't want it to get wrapped around their neck as they're sleeping. Slings should be at heart level. Lower extremities, you're going to use braces, crutches, so you need to teach them how to walk with crutches. You need to involve the patient's family in that education. Wheelchair, stroller, as it's indicated. And you may need to get a physical therapist involved to determine exactly what they need. Physical injuries, many childhood fractures does involve these, and about 27%. But it can disrupt growth of the bone, and injury is near but not at the physis can stimulate bone growth. Most commonly involved sites are your distal radius, right here. And a lot of times you can fracture that wrist along with some of your metacarpal and your phalanges. And that accounts for about 50% of injuries in kids. Clavicle fractures, hand, elbow, radius, tibia. But again, they're going to be classified as some of the pictures below that we've already talked about. Green stick, the buccal or torus fracture, remember Foch, and plastic deformation fractures. We can have simple fractures, which just heal up. We can have comminuted fractures, complex fractures, physical fractures, as classified by the Salter-Harris 1 through 4 based on the level of the growth plate involvement. That system, the 1 through 4, delineates risk for growth disturbance from the fracture. High-grade fractures are more likely to cause growth disturbance, but it can happen with any of the physical injuries. But a type 1, the fracture passes transversely through the physis, separating the epiphysis from the metaphysis. The type 2 fracture passes transversely through the epiphysis, but exits through the metaphysis. Triangular fragment. Type 3 fracture crosses the epiphysis and exits through the epiphysis at the joint space. Type 4 fracture extends up from the joint line through the epiphysis and out of the epiphysis. And type 5 is a crush injury to the growth plate, which is bad. Again, that torus fracture, the bone bends and buckles, Foch, but doesn't break it. It occurs commonly in the radius or ulna. It only occurs in kids because their bones are softer than adults. Many torus fractures are not diagnosed until days after the injury occurs. Treatment strives to alleviate the pain and prevent further deformity. No reduction is typically needed, and typically kids will wear a short arm cast for 3 to 4 weeks. If the injury is more than 24 hours old, it will be casted immediately. However, newer injuries are splinted for about 5 to 7 days before casting. And again, that's to let everything, all the swelling, to get out of there and see where everything is going to end up. Green stick fractures are incomplete fractures along bones that are commonly mid-diaphyseal. If it's non-displaced, this injury is typically treated with a short arm cast for about 4 weeks, and then a removable splint for about 2 weeks after that. If the fracture is displaced more than 15 degrees, it is reduced and immobilized in a long arm cast. Distal radial fracture. This is a common bone fracture that affects the radius in the forearm. Because of its proximity to the wrist joint, the injury is often called a wrist fracture. When displaced, the fracture should be reduced as soon as possible. A non-displaced is a short arm cast for 3 to 6 weeks. And if you don't know what that means, it's just like it sounds. A displaced fracture is where the bones do not line up, and it can be little. I can't do it really good. It can be just a little, or maybe it's like that, or maybe it's on top of each other. But A non-displaced fracture is where the bones are lined up. The older that the kid is when the injury occurs, the longer that they are immobilized. The child typically has tenderness over the growth plate, and the wrist should be immobilized and then re-x-rayed to determine how they heal. Elbow fractures are about 10 to 12% of pediatric fractures, and most are supracondylar fractures. Elbow fractures in kids are complex to diagnose and as well as manage. Think how much you move that elbow. And they have lots of immature bones, and it's also involving a lot of bones. You know, you have your humerus, your radial, your ulna, so lots of things there. Early recognition and referral will provide the best outcomes. You have supracondylar fractures, and that affects the weakest part of the elbow joint where the humerus flattens and flares. Peak incidence is about 5 to 7 years old, and it does represent 60 to 80% of pediatric elbow fractures. Most commonly, extension fracture is characterized by elbow pain and swelling. There is a potential for vascular compromise. Remember, when you're doing an assessment on these kids, you need to do the 5 Ps: pain, pulse, pallor, paresthesia, and paralysis. You need to know those 5 Ps for your exam as well as the NCLEX as well as your practice afterwards. Pain, pulse, pallor, paresthesia, paralysis. Put those on a note card, memorize those because those are all super important. If a pulse is compromised, a fracture needs reduced immediately. You do need to check that nerve function in the hand. Most supracondylar fractures are displaced and do need surgery. Non-displaced fractures can be managed with a long arm cast where the forearm is neutral and the elbow is at 90 degrees for 3 weeks. Follow-up x-rays are taken 3 to 7 days later to document alignment, and then x-rays are taken at 3 weeks to document that callus formation. Once the callus is noted at 3 weeks, the cast can be removed, the pins are pulled out in the office, and they start active range of motion slowly over the next 1 to 2 weeks. If no range of motion improves in 2 to 3 weeks, they need to be rechecked in the office and sent to occupational therapy. Lateral condylar fractures is the second most common elbow fracture. And again, it is a foosh, fall on outstretched hand, plus a varus force. So foosh plus varus force, and it causes a lateral condyle avulsion. On examination, you're going to see a focal swelling at the lateral distal humerus, and most are displaced and most require surgical pinning. If it's non-displaced, though, you can treat with casting a posterior splint with the elbow at 90 degrees, and they need weekly follow-ups to check for late displacement. If they're stable at 2 weeks, then they continue their long arm cast for another 4. Complications can be their growth can stop, as well as non-union of the bones. A medial condyle fracture is the third most common elbow fracture. It's very common among baseball pitchers between the ages of 9 and 14. It's an overuse injury caused by repetitive motion and increased muscle fatigue. Conservative treatment for non-displaced and stress injuries. Long arm splint or cast for 3 weeks. And if it's displaced, they are going to have surgery. Side effects include stiffening, ulnar nerve injury, and symptomatic non-union. And I didn't explain non-union a minute ago, but if it's non-union, that means that the bones do not grow back together. Even if the bones are lined up, they still just have that fracture. Clavicle fracture is the most common birth injury. It can also be caused by the foosh, a fall on the outstretched hand, but it can be caused when the kid is in the birth canal. It can be caused by direct trauma, like a car accident, or maybe they're in sports. But 80% of clavicle fractures occur in the middle third of the bone. 15 in the distal third, and 5 in the proximal. Patients with a clavicle fracture typically hold their arm to the chest and experience pain when the shoulder moves. Obvious deformity often occurs, and it is occasionally missed in infants until the callus formation causes a visible bump. Without trauma, if a kid develops this, the injury can indicate the presence of bone cysts, and abuse should always be ruled out. Remember, it's kind of like I talked about last week. It's not up to us to report if there is or isn't abuse. It's up to us to report suspected abuse. That's where the forensics and the investigators determine if it's abuse or not. Not up to us. We just report any suspicions. Surgery is often required of a clavicle if open fracture is displaced more than 100% of the width, if they have tenting skin, which is the bone is pushing the skin outward, if there's fracture pieces, or any vascularity compromise. Although a figure 8 bandage was once a standard of care, this can displace the fracture, which complicates healing. Most ped fractures of this kind can be treated with a simple sling, which provides comfort and reminds others to proceed with caution. When the fracture is fully healed, the shoulder's full range of motion will be painless. Kids can generally return to pain-free activity by 4 weeks, but should not be allowed contact sports for at least 6 weeks. And remember, they may get a bump in the injured area from that callus, but it will shrink after full healing, but it may not completely disappear. Tibia fractures occur when the foot is twisted during a fall. It takes a lot of force to injure the tibia shaft, and this fracture is rarely displaced. A posterior lower leg splint is required for acute fracture because swelling occurs 24 to 48 hours post-injury. Non-displaced fractures require a long leg cast for 6 to 8 weeks. They are going to have weekly x-rays to monitor the position. And surgery is required if the break angulates more than 15 degrees. Toddler fractures occur with children younger than 2 ages who are learning to walk. No specific injury is noted most of the time. The kid just refuses to bear weight on the leg. And so you are going to have to examine the hip, thigh, the knee, the foot, just to rule out other causes of limping. You do need to consider abuse. And spiral fractures are common. Examine for soft tissue injury to the buttocks, back of legs, head, and neck. Transverse fractures of the midshaft are very suspicious for child abuse. These kids are treated with a long leg cast for 3 to 4 weeks. Weight bearing is tolerated and heals completely in 6 to 8 weeks. About 20% of kids with an injury have a fracture. And again, you can always do bilateral x-rays if you need to compare. Physical injuries are common and may have no x-ray findings, so treat it as a fracture. Femur fracture is a diaphyseal fracture, or more commonly affects males and children older than age 3. A femur fracture is highest in the summer months and typically caused by trauma such as falls, sports, and car accidents. When this injury occurs in toddlers, though, you really need to consider abuse, particularly if they have a spiral or corner fracture. Treatment aims to restore length, alignment, and rotation. They can have traction pre-surgery if the bone needs to be reduced, and they may need traction for quite some time. Casting, they're going to use to apply stabilizing forces to prevent further injury. They often use plate and screw fixation, open reduction, external fixation where the nails or pins to hold a fracture is on the outside of the skin. So they often will have IV lorazepam, which is Ativan, every 4 to 6 hours as needed, and this can help with the muscle spasms. Typically, muscle spasms will subside once a spica case has cast has been placed, and that picture on your screen is a spica cast. So it can be all the way down both legs, depending on what the injury is, but they do leave a toileting hole. So if it's an infant, you need to stuff a diaper up in there. Super important to keep this baby or toddler, if the child is 1 or 2 and not potty trained yet, but keep their skin dry. They're high risk for skin breakdown. And your older child, they're going to be able to toilet, just like that. The spica cast can, I talked about it having two full legs. It may just be a half a leg on one side. You're going to turn and reposition this kiddo every 2 to 4 hours while they're awake to prevent the pressure sores on their heels and sacrum. It's extremely important to do neurovascular checks every 2 hours for the first 24 hours post-op. You need to insert 2 fingers down along the abdomen of the cast to verify it's not too tight. They a lot of times will have oxycodone for pain. You need to monitor for any kind of respiratory depression. You need to monitor for side effects. They can get really constipated from all the medication. So, we're going to encourage them to drink clear fluids, encourage consumption of fresh fruits and vegetables, decreasing fried foods and constipation triggers such as cheese and milk until they're off of the pain meds. Remember, they're also decreased physical activity, which contributes to the constipation. So lots and lots of considerations. Which of the following is a type 3 fracture? Is it A, fracture passes transversely through the through the physis, separating from the epiphysis from the metaphysis, or B, fracture occurs at the epiphysis and exits through the epiphysis at the joint space? Fracture passes transversely through the epiphysis but exits through the metaphysis, or D, fracture extends upward through the epiphysis and out the metaphysis. Answer is B. In a type 3 fracture, the fracture crosses the physis and exits through the epiphysis at the joint space. Congenital is abnormalities, and this, is something that begins in utero and the child inherits, so they're born with it. Some disorders, though, can be unrecognized until the child reaches a later stage of growth and development. Clubfoot is a congenital abnormality. It can be a neurologic or idiopathic. Syndrome develops include deformity along with physical or development defects. Lots of different things here. Risk factors and incidence. They can have it unilateral or bilateral. Family history increases the incidence. Males are affected more often, actually about like a 2-to-1 ratio. It affects the entire lower extremity. The calf looks smaller and less ability to develop muscle strength than a typical lower extremity limb. The affected foot may be smaller, and it's typically fixed and rigid in a plantar fixed and pronated position. The Achilles tendon is tight or shortened. Non-surgical is to start the Ponzetti technique of serial casting in the first week of life. The casts are changed weekly for up to 12 weeks. After casting is complete, the correction is either with ankle foot or orthotics. If the serial casting doesn't work, they do often have to do surgery. and that's where they release the tight muscles or scar tissue formation. They can do tendon transfers. They can align bony bone fragments to reposition a deformity. Metatarsus adductus is a common foot deformity that involves a forefoot only, in which the patient presents with the foot turned inward. It's more common than females. In males and females, it's bilateral. They have adducted forefoot, normal hind foot, and prominent fifth metatarsal tuberosity. And I'm going to let you read in the book on internal femoral torsion because I need to stop the recording here. I will pick back up on the next slide in just a little bit.